Hello and welcome, everyone. It's a few minutes after the hour, and so I think we're going to go ahead and get started. So I'm going to start with an introduction. Thank you for joining us today. My name is Sarah Foy, and I am the founder and president of Team Titin and host of this webinar, and I'll be introducing our speakers in a minute. Team Titin is a nonprofit with a mission to serve those living with, caring for, or researching Titin-related muscle and heart conditions. And the way that we achieve this mission is to focus on our four key pillars, which is connection, advocacy, care, and research. Next slide. The thing is, as far as a disclaimer, to please know that this webinar is for educational and informational purposes only. It's not intended to replace medical advice and diagnosis or treatment from your healthcare provider. And the information shared today reflects general knowledge about heart health and Titin-related conditions. And individual needs, as you know, can vary widely, so especially for people living with Titinopathies. Always talk with your doctor, cardiologist, or healthcare team before making changes to your care plan. So we just wanted to mention that. And now I'm so happy to welcome and introduce our speakers, Professor Diane Fatkin, and she is a molecular cardiologist with research interests in inherited heart diseases, particularly familial forms of dilated cardiomyopathy and atrial fibrillation. And also Dr. Renee Johnson, who works as a clinical research coordinator and genetic counselor with a particular focus on dilated cardiomyopathy and atrial fibrillation. And she is currently involved in research into genetic causes of dilated cardiomyopathy and atrial fibrillation and provides genetic counseling to participating research families and clinic patients. And both of these speakers are experts in Titin, and we're so grateful to have them with us today. So with that, I will turn it over to our speakers. Thank you.
Well, thanks very much, Sarah. Renee and I are very excited to be here today, and thanks to all the people in the audience who've tuned in for our webinar. And what we'd like to do is to share with you some of our recent research and also changes in current thinking about heart-healthy lifestyle tools for people with TTN-related heart conditions. So what we're going to do first is we'll hand over to Renee, and she's going to take us through some basic facts about Titin and also truncating Titin variants. So thanks very much, Renee.
Thanks, Sarah, for the introduction, and also Diane. Like Diane said, we're just going to start with general background, hopefully make sure everyone's on the same page. This is hopefully information that people already know, but just to make sure we are going to go through it again. So we're going to start just with a general introduction into Titin and Titin truncating variants, and then talk about some of the health conditions, and then we'll get into our research in a little bit more detail. So just to start, what is Titin and what does it do? So Titin is the largest protein in the body. It's a core component of all of the muscle cells, including those in the heart and the skeletal muscles, which you can see depicted in the diagram. And it plays a key role in the structure of those muscles, so how they're put together, and also how they function to contract and relax. We know that genetic variants in TTN are associated with both cardiac and skeletal muscle disease, and that's why a lot of us are here today. And then if we think about truncating Titin variants, which is really the kind of genetic variants that we're talking about, what do we mean by that? Well, Titin, the protein, is coded by the TTN gene, which I'm sure you've all heard of mentioned before. And if we think about our genes, when we talk about them in our cells, they're packaged into chromosomes. We have 2 copies of all of our chromosomes and all of our DNA, one from our mum and one from our dad. And when we're talking about Titin, that usually appears on chromosome number 2, which you may or may not have seen in a genetic report. And if we were to unravel that chromosome, we'd end up with a string of DNA. Now, truncating titin variants are genetic variants that actually shorten that titin protein. And we've got some examples here to show you what we mean. And so that might be, if we look at the DNA, we might substitute one of those bases to cause an early stop. We might have an insertion where we insert one or more bases into that DNA sequence, which changes the reading for the protein. Or we might actually take out one or more DNA bases for a deletion. And all of these essentially cause an early termination signal, which is why they're called truncating titin variants. And I'm going to refer to them as TTN-TV from here. So when I'm talking about TTN-TV, that's what I'm talking about. There are other different types of genetic variants, which we won't really be talking about for titin today, just these truncating ones. Let me get my computer to decide to change the slide. There we go. And so if we have a look at TTN-related heart and muscle disorders, we know that there are a lot of conditions that have been associated with titin in one form or another, but we really only have strong evidence for that association for those in the orange. A lot of you associated with Team Titin or having any involvement will know quite a bit about skeletal myopathies and titinopathies, where the skeletal muscles and sometimes the cardiac muscles are involved. But today, really, what we're going to be talking about is dilated cardiomyopathy, where we're looking at the cardiac muscles. Like I said, we know that there's a lot of other conditions, and some of these are represented here by the dashed arrows out to the little circles. But we know that for them, the levels of association for the evidence of titin in that condition are quite variable. So we just aren't as confident of them. And we won't be talking about them any further today. If we talk about dilated cardiomyopathy or DCM, this is a heart muscle condition that's characterized by dilation and impaired contraction of the left and right ventricles. And we've got an example of that in these echocardiogram pictures here on the right. So there's a normal heart here at the top and a dilated cardiomyopathy or DCM heart here at the bottom. And what you're looking at in this is this left ventricle here, which is a lot bigger and a little bit floppier than those in the normal heart. Usually, this is diagnosed by echocardiography or occasionally MRI, depending on where you are and what access you have. Most commonly, it would be echo, and that's what these pictures depict. It can often result in heart failure, in different arrhythmias, in heart transplantation, stroke, and death. And so it does have quite a large impact on people's health. And it has many causes, both genetic and acquired. And what we're interested in today, obviously, is those caused by TTN-TVs. And we know that TTN-TV is the most common genetic cause of adult onset DCM. It's mostly single variants, so one copy of the titin is mutated that occur generally in the titin A band region, but we'll discuss that a little bit more later. If we go on to have a look at our research, so we have done a large research study looking at families with TTN-TV-related DCM, and we were particularly interested in looking at what factors are associated with disease onset. This is just a little bit of a schematic about the study design. So we had over 3,000 family members from around the world, across 12 different countries. And really what we were looking at were the odds of DCM within these families. And we looked at what factors might increase or reduce these odds and used that to look at what that might mean for clinical care for those patients. And that's really what we're going to talk about in the next couple of slides. So one of the main questions people often ask when they get diagnosed with a TTN-TV is, if they haven't already got dilated cardiomyopathy, is what is their risk of getting DCM, or what is their risk for other family members? And that's what we're looking at in these families here in these graphs. If we start by looking at this graph here on the left, what we're looking at is the percentage of people with TTN-TV that get dilated cardiomyopathy across age in years. And these are in our families. So we've got people with TTN-TV, which are in the yellow, and also family members without. And really what we can see is for those people with a TTN-TV, there's quite a sharp rise from about 30 years of age in their risk, or the number of people we saw in our families getting DCM. And this increases right up until almost 100% when people were hitting around about 80 or 90 years of age. And really what that's telling us is that if somebody with a TTN-TV lives long enough, then generally they will experience some kind of heart problems throughout their lifetime. And that may be earlier for some people, or it might be quite late in others. And that's really one of the questions we're trying to answer with our research. We can also see that for the family members without a TTN-TV, they weren't at zero risk. So they did develop DCM for other reasons, though this was at a much lower level. And then if we look just at those people with a TTN-TV, and we look at different decades of age over their lifetime, what we can see similar to the graph is this increases quite rapidly. And if we look at this 50 years of age one as a median endpoint, we can see that just over half of males at this point in time will have developed DCM and just under 35% of females. So there's a difference in males and females in their risk for getting DCM. Females tend to be a little bit later than males by about 10 years. But overall, by the time they get to the 80s and 90s, the risk is quite high that they will have developed some kind of heart problems. One of the other questions we often get asked are about variants in the A band. And so if we think about Titin, it's actually separated into different regions based on where it appears in the muscle cell. So we go from the Z disc region through an I band region, A band region, and then an M band at the end. And most of the variants we saw, particularly in the initial studies, occurred in this distal I band and A band region, which is why you'll probably hear quite a lot about A band Titin variants. But what we do know is that as we look at more and more people and more families, we see that we get variants across this Titin gene, depending on how often that exon appears in the protein. We're not going to go into that, but that is generally an important factor for deciding what Titin variants to report. And so one of the questions we asked was, does having a variant in a different part of the Titin protein cause you to be at more or less risk than having a variant in the A band region? And that's what we're looking at in this graph here on the left. So same thing again, the percent of people with Titin going up vertically, across years going across horizontally. And as we can see with the yellow and blue bars, here that there are no difference in the risk of DCM for somebody having an A band variant, which is in the yellow, compared to a variant in any other region. So where your variant occurs in the protein didn't seem to matter. And then on the right here, we were having a look at whether or not the type of variant impacted your risk of getting DCM at a particular age. And so we've got nonsense variants, which were those substitution of a single base. We've got frame shift, which were the insertions or deletions that were causing an early stop. And we have splice, which is both substitution, insertion, and deletion, just at a very particular part of the DNA. And if we have a look at all three of these, there was no difference between the type of variant and your risk of DCM. So it was quite similar no matter what type of variant you had. And what this information tells us, didn't matter where your variant was, and it didn't matter what type of variant you had to get there. If you had a truncating Titin variant in one of these particular exons that we look at, then that would be important in your risk of getting dilated cardiomyopathy. So we know that there's something else going on. That means that there's some people that get DCM down at this end of the curve and other people that get DCM down that end of the curve. And so we were interested in looking at what those might be. And so I'm just going to talk you through the layout of this graph, and then I'm going to hand over to Diane to talk a little bit more about these personal risk factors. So when you're looking at this graph, we have this line running down the center, which is baseline. If you think about just baseline risk. So someone without a risk factor would be at baseline. If you have a risk factor or anything that pushes these dots over to the right-hand side of the curve, that's indicating an increased risk of dilated cardiomyopathy. Whereas if you have something that pushes those dots over to the left-hand side of the curve, like this one here, that's indicating a decreased risk of dilated cardiomyopathy. So even the people in the center still have risk. We do have people with DCM there, but we're looking at what things increase or decrease your risk depending on what side of the line they fall. And I'm going to pass over to Diane right now to talk to you a little bit more about each of these risk factors and what they mean.
Thanks, Renee. So this is a real problem when you're talking to families with Titin truncations. And we really don't understand when people are likely to get disease. And so you've got some people who are presenting with heart failure in their teens and 20s, and other people who are walking around pretty fit and well till later in life. And as you've seen from the data that Renee just showed you, looking at the Titin variant itself isn't the answer. And the variability does not appear to be related to that underlying genetic defect. So what else could be going on? And so what we did was to go back to individual patients and take a detailed medical history to see what other factors might be in the mix. And so the things that we looked at included clinical risk factors that are known to be associated with dilated cardiomyopathy. And we also looked at other cardiovascular risk factors which have been associated with heart failure, but not specifically with dilated cardiomyopathy. And the first big result, which I'd like to highlight, is when we looked at any of these risk factors at the top line there, then people who had one or more of these clinical risk factors had a 2.8-fold increased risk of dilated cardiomyopathy. And when we're talking about these factors, we're talking about things like atrial fibrillation, heavy alcohol use, some chemotherapy drugs, pregnancy, obesity, and then the general bag of cardiovascular comorbidities such as high blood pressure, diabetes, thyroid disease, etc. But the second big result, which we're very excited about, was for the first time we found factors that appeared to be associated with reduced risk of dilated cardiomyopathy. And so the first of these was drug therapy. Now, we have to remember that when people are identified with a truncating variant in a family, there's usually no preventative therapy. The regular management is to get people to have regular echoes, and nothing happens until you actually get dilated cardiomyopathy. So there's no information out there or guidelines about any kind of therapy that you might do to prevent dilated cardiomyopathy onset. So this was very interesting when we found that some of our family members who'd been on drugs like beta blocker drugs and ACE inhibitor drugs for other causes, such as, treatment for high blood pressure or treatment for palpitations, etc. If people had been on these drugs before their diagnosis of dilated cardiomyopathy, they tended to present with dilated cardiomyopathy at a later age. So this is really interesting. I mean, it's only observational data, and we can't go out and recommend these at this point in time, but it does suggest that prevention might be possible, and we really need to sort of further investigate that with clinical trials. The other interesting thing that we found was that people who had moderate to high levels of exercise also seem to be relatively protected from dilated cardiomyopathy. So this was another important and novel finding. So what I'd like to do now is to go through and look in more detail at some of these risk factors. So the first risk factor we're talking about is atrial fibrillation. And this had a very, very strong association with dilated cardiomyopathy. So atrial fibrillation is the most common heart rhythm abnormality. It's characterized by irregular electrical activation of the atrium and gives rise to irregular contraction and reduced blood flow. And it's important not only because it's common, but also because it increases the risk of stroke and heart failure. And the way we diagnose this is with an ECG, or sometimes it's identified in a Holter monitor. Now, the thing about atrial fibrillation and Titin truncations is that anybody who's got dilated cardiomyopathy due to any cause has an increased risk of atrial fibrillation. So you could say that this was just a non-specific complication in people who had dilated cardiomyopathy. The thing about Titin truncations is that some people can present with atrial fibrillation years before they get dilated cardiomyopathy. And often it's identified at the same time as the dilated cardiomyopathy diagnosis. So this has led to a lot of speculation and investigation whether the mutant protein which is present in the atrium is actually causing a fundamental defect of the atrial wall and causing atrial cardiomyopathy in addition to the ventricular cardiomyopathy that we know about. But the other thing to bear in mind in our families is that many of the people who did get atrial fibrillation before their dilated cardiomyopathy also had risk factors for atrial fibrillation. So I think the bottom line here is that there are potentially many factors contributing to atrial fibrillation in people with Titin truncations, and it's important that it's not just assumed to be due to the Titin variant and that all other factors are investigated. Next slide. So the next risk factor which we like to talk about is alcohol. Now, alcohol is something that people do all around the world. There are 2.5 billion drinkers around the world. And alcohol is something that is part of lifestyles. It's a marker of sophistication. It's used for celebrations. It's a core feature of social activities and having a good time with mates. But the next slide. But this all comes at a cost. And there are many effects of alcohol on the body, including the cardiovascular system. And the thing about alcohol, it can have a direct toxic effect on the heart and the cardiovascular system. And so often high levels of alcohol can trigger episodes of atrial fibrillation. They can contribute to high blood pressure. And importantly, people who drink very high levels on a regular basis can get a type of dilated cardiomyopathy called alcoholic cardiomyopathy. And so this is a real problem at that high level of the spectrum. But it's not entirely clear whether lower levels of alcohol are safe. So moving on, let's have a think about alcohol and Titin truncations. So what's the story here? So some years ago, there was a study of patients with alcoholic cardiomyopathy, so the very high levels of alcohol with dilated cardiomyopathy. It was interesting that about 10% of those people actually had a Titin truncation. This was not too dissimilar to what you might find in a group of patients who had dilated cardiomyopathy due to other causes. But in our study, we also found that having past or current heavy alcohol use was associated with a nearly twofold increased risk of dilated cardiomyopathy. And this was particularly seen and a particularly important risk factor in young males. So it seems that having a Titin truncation may give a genetic susceptibility to having toxic effects of alcohol impairing heart function. So the take-home message from this slide is that too much alcohol is harmful to the heart for anybody, but particularly if you have a truncating Titin variant. Next slide. So the question which lots of people want to know is how much alcohol is actually too much. When most people are not going to be in the alcoholic cardiomyopathy range of drinking 20 drinks a week, And so there's been different ways to measure alcohol intake to formulate recommendations. And so the usual way of looking at this is a standard drink. And there's lots of information out on the web about how you define a standard drink. And there have been different recommendations by different authoritative bodies. The US National Institute on Alcohol Abuse suggested that no more than 3 drinks per day for women and 4 drinks per day for men was an upper limit. But I think in patients with cardiomyopathy, and particularly for Titin truncations, we probably need to kind of be more cautious. And so the American Heart Association guidelines for patients with cardiovascular risk are really to limit standard drinks to no more than 2 per day for males or 1 per day in females. But ideally, cutting down to 0 is the safest way to go. Next slide. So moving on to another risk factor for dilated cardiomyopathy, and that's some types of chemotherapy. So it's not an unusual scenario for somebody to survive horrific cancer therapy, but to end up with heart disease. And in fact, heart failure is a major cause of death in cancer survivors. And it can occur up to 20% of patients, especially with some types of drugs, such as anthracyclines or Herceptin, and women with breast cancer are often in this kind of group. And the drug toxicity, it's interesting. I mean, there is an acute phase where you can get heart failure straight after the treatment, but it can occur weeks to months later, or even up to 20 years after the treatment. So it's not really well understood, what the factors are that contribute to this delayed disease onset. Some of the risk factors that people have thought about include a high cumulative dose if you've been given a lot of drug over a long time, or if you've got combinations of different drugs all adding up, or drugs and radiotherapy. And there are other risk factors such as being female, having other issues that affect the heart. But interestingly, a genetic predisposition to chemotherapy effects has also been suggested, and Titin truncations are one of those genetic risk factors for getting cardiotoxicity. Now, I have to say, in our experience, we had very few patients overall who had chemotherapy as a cause of dilated cardiomyopathy. However, in those patients who do have chemotherapy, Titin truncations are important. So the practice point here is that if you have a Titin truncation and you do have to have chemotherapy, then it's very, very important to have regular heart checks, both during the treatment and after the treatment to check for cardiac dysfunction. Next slide. Another risk factor for dilated cardiomyopathy that's relevant when we're talking about Titin truncations is peripartum cardiomyopathy. So what do we mean by this? This is a new onset of dilated cardiomyopathy that's usually severe, that occurs in the last month before delivery or in the first 5 months after delivery. And it's often severe, can often lead to heart failure, and can be fatal. Now, overall, if you look at all the pregnancies worldwide, it's pretty uncommon. It's thought to occur in about 1 in 15,000 deliveries. And nobody really understands the cause. There's lots of suggestions that could be hormonal, immune factors, nutritional factors, etc. But it has been, the question has been raised as to whether there may be a genetic predisposition. Now, when we come to Titin truncations, let's put it in perspective. If you look at all the women in the world with Titin truncations, by far and away, most people have a normal pregnancy. And we don't really have good data for the exact statistics of how many women with Titin truncations will develop dilated cardiomyopathy. But what we do know is if you take a group of women with peripartum cardiomyopathy, up to 20% might have a truncating titin variant. So again, this is something that, even though it's uncommon, it's something that we need to be aware of. And it's really important that any women who have a titin truncation get regular heart checks before and after pregnancy and delivery to look out for any evidence of cardiac dysfunction. Next slide. So alcohol, chemotherapy, peripartum cardiomyopathy, we've known about these as potential risk factors for dilated cardiomyopathy. But what about obesity? And this is something that we didn't really appreciate before our recent study. Now, obesity is a massive problem around the world, and this is just some Australian statistics, that 2 in every 3 adults in Australia are either overweight or obese. This is dreadful. And it occurs in young children, and then by the time you get to over 65, 4 in 5 older people are obese. And there are many reasons for this, including, you know, an increasingly sedentary lifestyle and crummy diet, and drinking too much alcohol or sugary drinks, etc. But whatever the cause, there's no doubt about it that obesity is related to health issues and is increasingly going to be a cost of healthcare expenditure. Next slide. So like alcohol, obesity has many effects on health in general and the cardiovascular system in particular. I'd just like to focus on heart failure. And it's been known for years that obesity is a risk factor for a type of heart failure called heart failure with preserved ejection fraction, or HFpEF. But what is less appreciated is the fact that heart failure with reduced ejection fraction, or dilated cardiomyopathy, is also relevant. And in fact, we were quite surprised to find in our study that there was a strong association between obesity and the risk of dilated cardiomyopathy in titin truncation carriers. So we now have to add watching your weight to the risk, to the list of recommendations for people who have a truncating titin variant. Moving on. So we've talked about factors that may promote dilated cardiomyopathy. What about factors that might protect against dilated cardiomyopathy? So one of the questions people with inherited heart disease often ask is, what should I be doing with exercise? Is exercise good or bad for my heart? And part of the reason why this is a huge conundrum in the inherited cardiomyopathy space is that there have been data out there that exercise might actually exacerbate disease progression with more wear and tear on the heart and may trigger cardiac arrhythmias. And this needs to be balanced against the health benefits of exercise for everybody. And so we really kind of need to know whether exercise is safe and beneficial for heart health or whether it's going to have adverse effects. And it's an important point to consider that the impact of exercise on the heart may differ in people who've got normal hearts compared to people who have a genetic factor that affects their heart function. So this may affect the impact of the mechanical stress of exercise and the likelihood of arrhythmias. Next slide. So this has been a very, very controversial area, and we wrote a recent review in Circulation Research on this topic, just looking at recommendations for exercise in inherited cardiomyopathies. And it's really difficult to make broad brushstroke statements because the effects of exercise are going to differ according to what type of cardiomyopathy you have, whether it's dilated, hypertrophic, or restrictive, or arrhythmogenic. They are likely to be affected by the type of gene change, and different genes may have different effects. It depends on whether you've already got disease or not, and how severe that disease is, and whether you've already had evidence of arrhythmias. There's a whole lot of other patient-specific factors, such as what your general health and what medications you might be on. And there's factors like the frequency, the duration of exercise, how hard you exercise, and the type of exercise, whether you're a walker, a runner, or a swimmer, etc. So there's a lot of variables. So what do we know about exercise and truncating titin variants? There's not really much out there yet. So in the last couple of years, this has been a topic of interest. And there was one study by Savanito et al. Where they did ask people to look at their exercise habits over a retrospective period of about 6 years. And they found that people who exercise for more than 4 hours per week did not appear to have worse LV function or arrhythmias. Then there was another small clinical trial which looked at an 8-week bicycle training program in 13 patients, but actually only 6 of them finished the protocol. And in this study where they looked at cardiac function before and after the exercise program, it did appear that exercise improved fitness and LV function. And then more recently, there was a study in UK Biobank, again, a historical study, which suggested that moderate to vigorous activity was associated with lowered risk. And then in our recent study, we did find this trend to a later DCM onset with people who had moderate to high exercise. Now, the problem with this whole area is that there's no standard definition. And as you can just see from this slide, people define vigorous activity in all sorts of different ways. So we really don't have a lot of data, and we are hoping in the future to sort of get some more formal information. And what we need is clinical trial-based evidence for exercise effects, not only for safety, but also for efficacy, and so that we can make some recommendations. Next slide. But at the end of the day, it's very unlikely that one-size-fits-all exercise programs are going to be useful. And it's very unlikely that we'll be able to pick up a medical magazine and see recommendations for people with titin truncations are. And where the field is going is to really look at individualized exercise prescriptions that take into account all sorts of things that we've mentioned before: the type of genotype, what sort of heart problem that you've got, are you a male or female, how old are you, what is practical for your lifestyle. And all of these factors need to be taken into account. And so the ideal situation is when each person can have an individualized exercise prescription. And hopefully that is something that we'll be working for and aiming for in the future. Next slide. So just to summarize this part of the talk, we now are looking at the risk of dilated cardiomyopathy in a different way. In the past, we've really focused a lot on whether there was a titin truncation, yes or no, and that was the main thing that we thought was the determinant of dilated cardiomyopathy. But we now need to take a more holistic view of heart disease risk and look at each person and the sum total of risk factors in each person. So we're not just talking about the titin variant. We're talking about other factors in each person's genetic makeup that may promote cardiac disease, or maybe that might protect cardiac disease. And then each individual person has a unique environment or combination of factors that may affect heart risk, including their age, sex, other heart conditions, other health conditions, medication, and lifestyle. And all of these factors all contribute to how the heart works uniquely in every person. Now, the good news about this is that you don't necessarily, if you've got a Titin truncation, you don't necessarily need to just sit around and wait for dilated cardiomyopathy to occur. Now that we understand all of these factors that may be involved, it empowers people to be very proactive and to do what they can to reduce their risk of dilated cardiomyopathy. Now, it's very unlikely that you'll be able to eliminate the risk of dilated cardiomyopathy, but certainly if there's things that we can do to reduce exacerbating factors and work on those protective factors, then that's very exciting. And that's what the New Year message is all about, that we hope people will embrace this information and really look at their lifestyles and their heart health and see what can be done proactively for yourself and your family members. So what we're going to do now is to move on and to look at some of the practical management tips and some advice that might be helpful. So next slide. I'm going to ask Renee some questions first and see what she thinks about these answers. So Renee, I've just been diagnosed with a Titin truncation. And my doctor told me that I have dilated cardiomyopathy, and I'm really upset about this. I've never had dilated cardiomyopathy before. And also my ECG is abnormal. What do I need to do?
That's a good question. It's one that we get quite often. So I guess current guidelines really limit this to having regular monitoring with your cardiologist and using standard medications to treat the cardiomyopathy and arrhythmia. And there's lots of different medications that are being used now. It might take a little bit of time to find the right ones, but they're generally the main things that most people are going to be doing. There may be some discussion about looking at maintaining a heart healthy lifestyle. And as we've seen from the talk so far today, hopefully really identifying and aggressively treating those other cardiovascular risk factors is likely to be important. And generally occurs, but I think now that we've seen that this is a lot more important, and we can talk a little bit more in the next couple of slides by what exactly we mean by that. But certainly these are changing, mainly that regular monitoring. So keep seeing your cardiologist, keep going with medication. You might take a bit of time to find what's working for you, and then work on maintaining that heart healthy lifestyle and treating any other risk factors that occur.
Thanks. So the second scenario is I'm a family member. My mum's got dilated cardiomyopathy, but I've been told I have a Titin truncation variant that I got from my mum, and the doctor said my heart's normal. What do I have to do?
We see lots of family members, and at the moment, really the only thing we can be recommending for them is regular screening and monitoring their lifestyle. Now, this is changing, and it is likely to change over the next few years. We may be able to do some pre-treatment once we've done some clinical trials to work out what works best. But at the moment, the main things that we would be asking people to do would be to have a regular echocardiogram and ECG to monitor your heart health. Now, the timing of that might depend. So we say anywhere between 1 to 5 years. And it often depends on what results you get back from your echocardiogram in particular. So if your heart has changed size, or if the pumping action, so the ejection fraction, has gone down a little bit compared to your last echo, then your cardiologist might want to see you in a year or maybe even 2 years. If everything is quite normal and you're very young, they might wait for 5 years. So it really depends on what kind of results you are getting. And then once again, our information suggests that identifying and treating those cardiovascular risk factors before you get dilated cardiomyopathy is really important, as well as maintaining a heart healthy lifestyle. And in general, these are information that's given to patients, but what we're able to do now is provide a little bit more specific information about risk factors for those family members. And so if we're looking at what do we mean by a heart healthy lifestyle and what recommendations would we be now adding to that regular screening and monitoring with the cardiologist for people who are affected, if we look at our general health, really what we're saying is monitor and treat for things like atrial fibrillation, for high blood pressure, for coronary artery disease, diabetes, thyroid disease, and chronic lung issues. So that might be things like sleep apnea, it might be things like chronic asthma or other respiratory diseases. And we're also suggesting people will have extra monitoring during and after pregnancy and chemotherapy, as Diane mentioned earlier, because we know that these can be risks for dilated cardiomyopathy. And if we can see that there are changes in someone's heart early, we've got a lot more options for treatment at the moment than we do if someone gets very ill. So certainly monitoring and treating these, particularly when you're young. So a lot of these are conditions that we all can have risk of as we get older, and we tend to be quite well monitored as we get into the later decades of our lives. But we really don't monitor younger people for a lot of these conditions, and that's certainly very important, as well as continuing to monitor and treat as we get older. And then if we think about lifestyle changes that we could all make to improve our health, that are particularly important for people with TTN-TV, so things like reducing your alcohol consumption, we know that it's not realistic to suggest that everyone has zero alcohol. It would probably be the best for your heart, but people are likely to want to have a drink. We're saying don't drink to excess, and reduce that as much as possible. If you can make that zero, that's great. If you can't, then reducing that is better than doing nothing. Avoiding recreational drugs because they also have a toxic effect on the heart, and then maintaining regular exercise. So as we're young, we're often doing a lot and we're very active. As we get older, we do tend to lead less active lives, and a lot of us are sitting in front of our computers, which I do myself. So maintaining that regular exercise is important. As Diane said, that there's no good guidelines on how much and what to do at the moment, but certainly doing what you can is better than doing nothing. And then maintaining a healthy weight is important, as we've seen as well. So all of these things are little changes that people with a TTN-TV can work to make that reduces their risk, not only of dilated cardiomyopathy, but also of those other heart conditions that increase your risk as well. So I know that this space is changing quite quickly. And so, Diane, do you want to talk through some of the future research directions that are currently going on at the moment or are looking like coming in the near future?
Thanks, Renee. So this is a very exciting time in Titin-related research where we're really hoping to change the direction of our research. So based on our recent data identifying risk factors, we want to really get better at more precise risk prediction of when dilated cardiomyopathy may occur. And this is important for screening guidelines. And this is important for counselling family members, but also will be increasingly important as we work towards identifying and implementing disease prevention strategies. So if we really understand within a 5 or 10 year time frame who's likely to develop dilated cardiomyopathy, we can really sort of target these people and these age groups to preventative therapies. And we'd like to explore things like exercise and drug therapy for disease prevention. And there's probably people have heard of gene therapy in the Titin truncation space. People are working on this. It's a bit of a crystal ball, and who knows how widely it's going to be implemented and if it'll be successful. But there are people trying to edit the genetic makeup to see if we can cut out the titin truncation from the genetic makeup. This sounds very futuristic, but it may be possible, and is something that watch this space, and who knows what will be happening in the future in this direction. So that's pretty much all we wanted to cover today. We'd like to point out some very important resources for people who want information. And I'd like to have a big shout out to Sarah and the whole Team Titin team, who are doing a fantastic job to support families and promote information and education. And Sarah did all the groundwork for organising our webinar today. So thanks very much, Sarah. There are also patient support groups in Australia and in other places around the world for people who are interested. So what we might do now is to move on to our question and answer session. So we have some questions that people have already put in for us. So if you've got any more questions, just pop it in the chat. And I'm going to get the ball rolling by asking some tricky questions to Renee. Now, the first question from one of our listeners, Renee, was, please help me understand the high penetrance rate of an A-band truncating mutation and what percentage of people develop heart disease.
Thanks, Diane. Hopefully we've answered this through the talk. So as we saw in our families, and we have to make a qualifying statement that this was in families with a very strong family history. So it may be different in people with no family history of truncating titin variants or DCM. But for those families, the risk of developing heart disease over your lifetime was quite high, but the age of that was quite variable for a lot of people. In terms of A-band truncating variants, what we know is that we've seen quite a lot of them, and so we know more about them, which is why I guess there's high penetrance rates for that. What our data have shown that the chance or penetrance of DCM in developing in someone with a titin truncating variant is pretty much the same no matter where that variant is at the moment. And so it doesn't suggest that there's anything special about the A-band other than we see most of our variants there.
Okay, so somebody has just found that they've got an ejection fraction of 30%, and he was told that it was due to one titin gene variation. This is a 55-year-old male who feels well. What are the options for him?
That's a good question. It's good that you know now. It's not likely to change your treatment at the moment. So the most important things for you would be to be talking with your cardiologist, who you're hopefully seeing, and look at starting some of those regular medications that they're using to treat dilated cardiomyopathy. And what we know is that most people with truncating titin variants do respond quite well. Everyone's a little bit different, so sometimes some medications will work better for some people than others, so you may have to persevere a little bit. But certainly working with your cardiac healthcare team to look at ways of using medication to help take the burden off your heart and improve that ejection fraction would be important. It's great that you feel well at the moment. Hopefully you can continue to do so, but certainly looking at those other risk factors. So making sure you don't have any other health issues that might be impacting your risk of dilated cardiomyopathy. And if you do, treating those, but also then looking at your lifestyle and seeing if there's things you might be able to make small changes for that can improve your health, that will hopefully help that ejection fraction rebound for you.
Okay, so what are the best screening and yearly monitoring preventative tests?
Like we said, the most common ones are going to be an echocardiogram and an ECG. Depending where you are in the world, some centres might be using cardiac MRI. Here in Australia, most commonly people are going to be getting echocardiograms. they would be the ones you'd be wanting to look at. So the echocardiogram is going to be an ultrasound test that looks at the structure and the function of your heart. So it's looking at your heart size and the pumping action. And the ECG is going to look at the electrical activity and check for things like arrhythmias, so things like atrial fibrillation, that they can pick up through that. So they're going to be the main ones. It might vary depending where you are. If you are having some funny heart rhythms, you might get some extra tests, but they would be the two most common ones that you should be having. The frequency, like we said, will depend on what kind of results. And for some people, that might be yearly, some people might be 2 years, and some people might be more.
Okay. Now we've got two questions here, which are sort of the same question, which is about responses to therapy. So one question is, are there cases where recovery is sustained permanently? And then related to this, after starting Entresto, metoprolol, Jardiance, and spironolactone, my ejection fraction went from 20% to 40%. What is my chance of relapse?
Okay, I'm not sure if I can get this screen up, but let me see if I can. One of the PhD students, who's also a cardiologist here in Australia that worked with us, did a study. It wasn't just on Titin variants, and we don't have specific information, I guess, about after treatment with things like Entresto. But what they found is, over 80% of people generally improved in that study after treatment, and some of those would go on to have some episodes where their function deteriorated but improved again. And these were often sort of precipitated by things like heavy alcohol, a new arrhythmia, things like that. So significant weight gain, changes in their general comorbidities such as hypothyroidism, so thyroid disease. They could all precipitate a reduction in EF. Whereas things like removing some of those, so reducing alcohol, treating arrhythmias, treating hypertension and things like that would precipitate an improvement. So certainly there is studies that do show improvement in individuals after treatment. It's not specifically Entresto. It's not always consistent, so people do tend to go up and down. And there are a small number of people that do deteriorate, unfortunately, for other reasons beyond their control. But there certainly is recovery that happens. Most people will probably find that they do sort of go up and down. It's not sort of a one-way trajectory. You might find that as you go through life, if you have a virus or if something else happens, your EF might go down. And then once that resolves, hopefully your EF will rebound as well. But there is certainly chances of recovery, and there are some cases of relapse that we see. Most are positive if you can treat the causes for that relapse.
Yes, I'd just like to add a few comments there. I think the thing is that most people with Titin truncations tend to respond well to therapy. You have to kind of bear in mind that there's multiple factors, as Renee said, and it really depends on what else is going on. And you might have a very good response to therapy, and then you get a nasty COVID infection. And that's something that was unpredictable. And then the heart function may dip down. And then you might recover from that and then, get back to where you were before. Or if there's been damage to the heart, it may not get back to what it was before. So it's very individual. And the way we kind of think about all of these things is there's the Titin effect. There's the effect of underlying risk factors, which are there all the time. And then there's triggers, which may come and go and that are very unpredictable. And all of these things can all add up. But I guess one thing to say is that if you've got a Titin truncation, the risk is always going to be there. And then even if your heart function gets back to normal, it doesn't mean to say that you can stop your treatment. It's a good thing, but you will need to stay on your treatment to keep the heart function in that normal level.
This is Sarah. I just wanted to jump in because there was a couple of questions in the chat, but one of them is along the same lines of this discussion, which is about for peripartum cardiomyopathy and the long-term trajectory. Let's say you have peripartum cardiomyopathy and then you recover. What is the long-term recovery or trajectory for peripartum cardiomyopathy related to Titin?
Now, this is a really interesting point because peripartum cardiomyopathy often, if you don't have a Titin truncation and you're just a regular person with normal heart function to start with, peripartum cardiomyopathy is often very transient and people will get back to normal. But I must say, it's often that the people who have an underlying genetic change, whether it's a Titin truncation or a Lamin variant or whatever, they're the people who may not get back to normal function after a peripartum episode. So I think it's related to a number of factors. There's no one answer for this, but it is a suspicion for doing genetic testing if people don't recover completely back to normal after peripartum cardiomyopathy. That's not often when you think that, well, I wonder if there's a genetic susceptibility happening here. And that's often the first time when the genetic testing is done, when somebody doesn't bounce back to normal function after peripartum cardiomyopathy. But like everything else, it's not all good and it's not all bad. Some people will improve if they've got a Titin truncation. Some people may not improve, and there are a small number of people who continue to go downhill and may actually even need cardiac transplant in this scenario.
Sorry to interrupt you. Renee and Dr. Fatkin, if you're able to see the questions in the chat, or do you want me to read you a couple of them?
See a few of them. I've got one here from Lance asking about have any studies been done as to the durability of heart failure with reduced ejection fraction recovery after Entresto, given it is a relatively new drug, and has Entresto been particularly effective when treating DCM due to TTN-TV? I'm not sure, Diane, did you want to comment on that one?
Well, I think the thing is that in this day and age, people don't think in terms of single drugs. I think the guideline-directed medical therapy is all about a little bit of several drugs. So I wouldn't focus particularly on Entresto or a beta block or anything in one thing. I think the standard of care is that you use small doses of several drugs that all act differently, and so it may you may be kind of killing multiple birds with several stones here.
And I can see one from Pat as well, which we might come back to as well, which is quite a good question. But we'll keep going with the other ones, Pat, and then we'll come back to that. And then Sarah, if there are any others that we miss, let me know. So Diane, I'm going to ask you a few questions now as well. So we've got him here about, I would love your insight on A, whether any amount of alcohol use is safe, and B, tips for managing central sleep apnea.
All right. Well, I hope the person who asked this question was listening to the slide where we talked about this. Basically, alcohol is not good news for anybody, but particularly if you've got a Titin truncation. And, the current recommendations are really to limit standard drinks to no more than 2 per day if you're a male and 1 per day if you're a female. And anything above that is not recommended. And basically, alcohol is a toxin. So the more you drink, the more it can impair the heart function. And so I think it's one of those things that, is very straightforward, that the less you can drink, the better. And if you can avoid alcohol altogether, that's the best option. Central sleep apnea, I think, is this is a common problem that is often related to obesity and its risk factor for atrial fibrillation. I think there are, this isn't our particular specialty. I think if there are things that you can do with posture in the bed and with CPAP devices, etc. Best to speak to a specialist. There are sleep specialists if this is becoming troublesome.
Thanks, Diane. So we've got one question here with sort of two parts. So the first part is about exercise and the other part is about alcohol. So the first part is, I'm very interested to learn about optimized exercises for weight loss. And the second part was, how does alcohol interact with TTN mutation?
All right, that's a tricky one, isn't it? So weight loss, well, we haven't got any secrets about that. It's pretty straightforward. Calories in and calories expended. So it's all about having the total amount of calories you eat, having the right kind of calories that give you a good balanced diet, and maintaining exercise at the same time so that you're increasing your metabolic rate. So I think there's lots of lifestyle advice that you can get from nutritionists and exercise physiologists, but it sort of all boils down to not eating too much and keeping your exercise going. The other question about the alcohol, this is really interesting and something that we've been researching. There's two possibilities. One is that Titin truncations affect the heart in one way, that we know alcohol's a toxin, and that the two things add up. And if you've got two things that impair heart function, they're going to add together. But there's another interesting way of looking at this, which is that they may have synergistic effects. So that and this is kind of what we're thinking about alcohol, that in a Titin deficient heart, that the effects of alcohol may be greater than in a normal heart. And this may be because of different biological pathways that are interrupted, and that there may be multiple hits along the same pathways. We don't really understand it, but the current thinking is that the 1 and 1 make 3 when it comes to alcohol and Titin truncations, not 1 and 1 make 2.
Excellent. We've got a few more questions about exercise as well. So two of them are quite similar. I'll read them together. So one of them is, does consistent aerobic exercise delay disease development, and can it delay disease progression? And then a separate but similar question is, will exercise, either strength training or cardio, help or compromise my general health or longevity?
Okay, these are very difficult to answer sort of simply. So with we need to think about all those factors that we talked about. So there's the type of exercise, and certainly cardio is good for you. Strength training is good for the muscles and bones, but it doesn't have the same cardiovascular benefits as cardio. And there's different types of cardio that you can do, walking, running, swimming, cycling, whatever. And really, it's important to work out what sort of exercise you like, what exercise works for you and your lifestyle. But then also to sort of, talk to an exercise physiologist to sort of work out a particular training program that will be challenging, but not too challenging, because we really need to work out what's beneficial in each particular person. And in this day and age, I think we're working towards allowing more people to do more exercise and working out where the upper limit is, rather than in the past, which was very much a cautious approach, where people were worried about exercise potentially having disease progression and etc. And so people to err on the side of not exercising to be safe. So I think the challenge now is to work out what works for each individual and how much is too much and how much is beneficial. And really, there's no easy answers for this. I think we need a lot more research, but we do really need each person to think about this and be personally assessed, because what works for you may not work for somebody else.
Excellent. We've got two more exercise-related questions. So one of them is limiting activity minimizes both my neuromuscular and cardiac symptoms. Is that typical? And then the other one is asking about cardiac rehab or exercise training and whether that's available to people and how they can access it.
Okay, well, I must say, if you don't do anything and you sit in a chair all day, it may minimize neuromuscular and cardiac symptoms. And I can understand how some people might feel like that, but that's not a good plan, because you can get loss of muscle mass and increasing muscle weakness, and lack of fitness if you don't use your muscles. And so while that might limit symptoms over the short term, it's likely to promote symptoms over the long term. So we would be very much advising people to try and fit in as much exercise as they can, for their limitations and for their condition, but as much as possible, both strength for the muscles and cardio for general fitness. What was the other question? Sorry, Renee.
The other question was about cardiac rehab or exercise training. Is it available to people and how do we access it?
Right. Well, we might flick that one over to Sarah, because I'm not sure what the situation is in the US. Certainly in Australia, there are exercise professionals, physiotherapists and exercise physiologists. But I must say that this is probably a gap that we probably need more medical professionals who understand how to write a personalized exercise prescription. And so, one of the things we have been thinking of is trying to get some experts together and get some guidelines happening, because if we're really telling everybody to have a personalized exercise prescription, it is a question of where to go, and ideally this should be something that people could potentially talk to their GP about, but at the moment, in Australia, we would go to an exercise physiologist. Sarah, what's the situation where you are with respect to this kind of question?
I would say that that's definitely a question they should bring to their care team, because it will vary based on your region and your insurance models. But I know that it is available in the United States and in the United Kingdom. There's some actually the Pumping Marvelous Foundation is an organization that supports people with heart failure, and they actually have I think they have an online exercise program that they run with individuals, and I'm not sure how they do that exactly, so that they make sure to meet their clinical needs and the parameters set out by their healthcare team. But I really highly recommend that it is a question you should definitely be asking your healthcare team about. The other thing I want to mention is we're past time for our webinar, and I know we could really listen to you guys talk about this stuff all day. You're excellent experts, and there's so many questions. And so maybe we could just, if you want to either take a last question or have some closing thoughts, and then we'll wrap up for the evening, or whatever, the evening or morning, depending on your time zone.
Well, we're very happy to answer more questions by the email, but I think the one thing, this webinar is entitled The New Year, New You. The one message we would like people to go home with was, go and do it, get active. You can do positive things to improve your heart health, and we would like to encourage every person to sit down and think about, what can you do in 2026 to work on your heart health, especially if you've got a Titin variant.
I'm just making a note of some of the questions in the chat here at the moment. There's some very good questions. Sorry, we haven't been able to get to all of them. We will certainly answer these questions as well, and get some information back to Sarah to pass on to everyone. If anyone has any other questions, please feel free to contact us, and Sarah, feel free to add our contact details to the email you send out to the participants as well, so that they're able to do that if they would like. I know sometimes it's hard to think of questions on the go, and you think of a great question 5 minutes after something's finished. So if you do have a burning question that you would like to add, please feel free to send that to us as well, and we'll get back what we can to Sarah. I think you're on mute, Sarah.
Thank you. Yes, thank you, both of you. And I just wanted to also mention that for most members of the Team Titin community, they receive a welcome letter, and it has your contact information on page 2 with the email. And also on our YouTube channel, there are videos from you. Renee and Diane did presentations for us also, and I believe their contact email is in the bottom of the video description. And of course, I'd be happy to, when I send out a summary. So this webinar was recorded, and assuming everything technically went very well, we'll post it and I can send it out to people, rehash things, and we can also include some additional answers to questions. And we had resources presented today. And anyway, I just, first of all, thank you for your research, which was really extensive and very deeply appreciated, so that we can start to build. There's, as you can see, so many questions, and we're starting to really build the answers to these questions together. And I want to thank you so much for your presentation, for your time, and your ongoing work. It really matters to us.
Thank you for Sarah, if there's any, I'm not sure